proceed?
Yes, you can.
So this is a talk actually after I was invited, thankfully, by Dr. Amna and the organizing committee to have this uh, talk about, I would say this rather now, rare entity of developmental hip dysplasia patients. They are complex. And the question now, as you have seen with Dr. Amna cases presented, whether to treat them by pediatric orthopedic way or leave them for our expert arthroplasty colleagues, which is better for the patient from functional point of view. I will try to take you through some of the literature, some of the, I would say, experience we have been through, some of the cases. And I hope, inshallah, with the discussion with the more senior surgeons attending, we will get a better idea about this complex rather than, I would say, rare entity now. So we agreed that good hip function is very essential for normal activity. Hip actually is there in daily sitting, walking, running, sport activity. So having a reasonable hip function is essential for a normal activity and good quality of life. So it's not easy to take a decision about the hips for humans. You have to take them with more granted results if you want to interfere. We know as well that DDH is very common pathology, if it is not the commonest pathology in pediatric age group, and it has variable presentations. And this presentations we are talking about is a unique presentation, which is the delayed neglected ones. DDH, as you know, is the outcome of treatment is strongly age related. If you treat a newborn with a Pavlik harness, you will hardly recognize that they have DDH. If you treat a neglected child at walking age, you might see the scar of the osteotomy, but they might live long. But as they are growing up, you will definitely have a worse outcomes. And we need to agree upon something that arthroplasty definitely, and I think Dr. Imran will show us, is rapidly progressing. They are talking now about 30 years survival of total hip replacement if it's done well following principle. So I think some of the heroic surgeries or salvage procedure done by pediatric orthopedic with this fact is now questionable, indicated in certain cases. More examples, what to do for this one, unilateral cases, change, I would say, in age, acetabular morphology, femoral head morphology, presence of osteoarthritis, or absence of that. All these are factors to decide whether to go for surgery or not, to treat them again or not. I think the most important question to answer, what will happen to those children if you leave them without treatment? So it's a natural history of a neglected, not treated developmental hip dysplasia. And I think one of the best thing written about that by Stuart Weinstein, Professor Stuart Weinstein from Iowa University. He wrote a very nice article in 1978 in Clinical Orthopedic and Related Research, and he picked up so many important articles in the field. One of them is this one, Wedge and Weslensko reported 32 patients with 42 complete dislocations in patient age 16 to 86 years of age. 41% of them, they have a good function, good quality of life. Imagine that. Nobody touched them and they are living happily, 41%. However, 45% they have poor function and disability, and 16% are fair. Keep in mind those percentage because we need to compare it to the surgical outcome in those complex cases we are talking about. The main prognostic factors those authors found to have a bad or good outcome in those neglected cases without treatment, whether the patient is having bilateral symmetrical involvement, this will be in favor of the patient. If you have a patient with bilaterally neglected, delayed presenting at the age of 15 years, with no ligament discrepancy, they tend to have better outcomes functionally in their future life. Is there a false acetabulum or no? The false acetabulum considered to be a negative prognostic factor. Those patients with well-developed false acetabulum, they tend to develop osteoarthritis early in life. So those are the main prognostic factors in completely dislocated hips. Those with, I would say, less involvement, dysplasia or subluxation, Most of the articles presented by Weinstein in his review article said that a pure dysplasia is unpredictable. You can't say that this patient 100% will have osteoarthritis in his life if he's having only pure dysplasia, regardless what angle you are using, whether you use a Stabler index, central edge angle of Weiberg, or sharp angle. The moment you have pure dysplasia with no subluxation, the outcome or the natural history is very difficult to predict. But if you have subluxation, the outcome is worse. And you expect the patient with dysplasia and subluxation to have osteoarthritis in their third or fourth decade of life. So in conclusion, if you have patients with complete dislocations, look to the symmetry, bilateral or unilateral, and the presence of fossa acetabulum to, let's say, have an idea about their natural history. If you have dysplasia, look if they are located or subluxated to select the treatment for your patient. It's quite important to know what our Saudi patients are looking for. You see, most of those articles mentioned in the Western publications, they are talking about pain, osteoarthritis, quality of life. But you see, in Saudi population, we definitely have some specification. For girls and young ladies, I think the appearance of a limb is quite disappointing, and it's quite socially embarrassing. And we need to keep in mind that this thing might be the reason for the patient to die for having early surgery for their neglected case. So definitely we have specificity about our patients and our disease. And I think the treatment also in Kingdom of Saudi Arabia, um, the treatment of neglected DDH cases, I wouldn't say the delayed ones, but the neglected cases after working age goes to two routes actually. The first one is in University Hospital, King Saud University Hospital Fellowship, led by Professor Ma'moon. He trained a lot of people, and a lot of people graduated since then. And the other one in King Faisal Hospital with my mentor, Dr. William James Wade, and those actual protégés, they have their own technique. We actually share more or less common steps. In Saudi Arabia, we do open reduction through anterior approach. We do femoral shortening, derotation, osteotomy if needed through a separate lateral incision. Rarely or seldom we do varus osteotomy. The pelvic osteotomy is done for DDH is either Pemberton or Dega with modification, either auto or allograft are used. Sometimes K-wire, if needed, are used for DDH if residual instability is still present after pelvic osteotomy, and definitely spica cast after treatment. If you track the literature from Saudi Arabia about treatment of neglected cases, you will find an excellent outcomes exceeding even North American ones because it's an endemic disease in Saudi Arabia. We have an early success rate exceeding 95% because it's our disease and we know how to treat it mostly. But unfortunately, we don't have reported series of those neglected, delayed presenting cases to extrapolate some results about our patients. So what to do? To treat them or not? We need to get a guidance. We need to get a results. What is the upper age limit of surgical treatment? What are the clinical, radiological outcomes? What are the factors affecting the outcomes in those patients? Clinical and radiological, just a quick review. Most of the articles in DDH will mention Mackay scoring system. For the people who are not familiar to Mackay, excellent is stable, painless, no limp, negative Trendelenburg sign, and full range of motion. Failure or poor, let's say, poor results is unstable, painless limp, or positive Trendelenburg sign, or severe limitation of range of motion. Not that accurate, not that, but it is the only one used for DDH cases. For radiological outcome, Severn definitely in all the publications is there. If you have a round femoral head with normal appearing C angle more than 25, you are having an outstanding results graded as 1. If you have redislocation or dislocation in the fossa acetabulum, you are talking about 5 and 6. So they are actually grading 4, 5, 6 are poor outcomes, and we will see the literature there. So 1, 2, maybe 3, they are considered to be good outcome, good radiological outcome from DDH treatment. 4, 5, 6 are poor outcomes. I think if you want to know the natural history of this combined treatment, open hip reduction, pelvic and femoral osteotomy done for older children. I think you need to read for Predrag Klizic, a prominent author, Yugoslavian, has a prominent experience in pediatric hip. And his two articles, the one published in 1976 with short follow-up for his technique, and the long-term follow-up published in 1988, will definitely give you a clear imagination about the outcomes. The technique is a bit different from the Saudi one we are doing here, but I would say it's again open hip reduction, pelvic and femoral osteotomies. Predrag Klizic mentioned three facts in his, I would say, introduction of the first article for those neglected and delayed ones. It's difficult to bring the femoral head down. If you bring it, it's difficult to maintain it. If you bring it and maintain it, it's very difficult to get a satisfactory function for the hip joint. It's a dilemma. In the long-term follow-up for Klizic study, 225 hips in 189 patients, age between 7 and 15 years of age. Average follow-up, 5 years, from 1 to 24 years. Clinical outcomes were collected for 144 hips. See the outcomes now. For all the cases, you are talking about 40% of poor radiological outcomes and more than 60% of good radiological outcome. Again, in all ages, you have 23 poor clinical outcomes. The beauty of this Klizic article that they divided the groups to certain ages, from 7 to 8, from 9 to 10, and from 11 to 15. If you see the real delayed presentation, what we are talking about is 9 to 15, 9 to 10, they percent. Clinically, more or less the same. You are talking about more than 40% poor in 11, 15, and more than 30%, 35% in the 9 to 10 age group. It's very interesting what they mentioned in this article. If you have this patient, God forbid, you operate on him and he redislocated, revision surgery carries a very poor outcome with 4 of them, or let's say more than 50% will not have a good outcome. So think twice before revising them. Another article, 1995 by Caracas from Turkey, more or less the same. If you focus on the older groups, 8 to 17, you are talking about clinically almost 40% poor outcome, radiologically even more. This short case series from a colleague in Iskandariya, Dr. Tayyibi, in 2009, shorter, I would say, or a limited number of patients, 19 hips. He's showing a promising results. Different technique, one incision going anteriorly and also doing the lateral approach for the femur in single incision. I would say it's a short series. You can't drag conclusions. This big study from China by Ning and colleagues in 2014, I hope that similar articles will be done in Saudi Arabia. 864 hips were treated surgically, so all of them considered neglected. And 3 different age groups. The young ones from 1.5 to 2.5, 206 hips. Middle age, 2.5 to 8, 576 hips. The older ones, more than 8, 82 hips. What's the outcomes? This is the demographic of the patients. Some of them, they have Tunis grade 1, 2, 3, 4. So it's variable kind of severity. But in general, we are focusing on the older age group beyond 8. What is the results of the radiological results of treatment? You are talking about 40% poor outcomes, severance 4, 5, and 6. If you see the clinical outcomes, you are talking about almost 60 or 70% of poor outcomes in the older patients. They also highlighted a unique fact that in Tunis 2 and 3, they have a higher rate of redislocation and a higher rate of residual acetabular dysplasia. So you keep an eye on them when you do a neglected cases of Tunis 3 or Tunis 2. This is a short systematic review. They included 9 studies, and they found that 60% have acceptable clinical outcomes and 90% acceptable radiological outcomes. So in conclusion, it's a short review of what has been published about this difficult and unique problem. Surgical treatment of neglected delayed DDH after the age of 8 is complex and unpredictable. Every case is different from the other, multiple surgical options, and they have a very long learning curve. And if you have limited number of patients, it will take from you almost 10 years to feel comfortable operating with them. Surgery, believe me, it's a quite demanding for pediatric orthopedic surgeon to operate on a 10 years old child. You need a different bed to do your pelvic osteotomy because you are used to use a small operative bed to do your pelvic osteotomies. You need a bigger radiolucent table. You need a big retractors like arthroplasty surgeons. You need big scissors. You need a big lamina splitter. So you need to prepare yourself for the procedure very well. You need something, you need to think about the spica when you apply it, how to apply it for a 40 kg child with a height more than 120 centimeters. Intraoperatively, reduction of the femoral head can be achieved by femoral shortening osteotomy. You can reduce whatever you want, but can you maintain it? If it is irregular, not matching the acetabular size, you will cry, believe me. Femoral head morphology. If you have a deformed, flattened femoral head, osteoarthritis, stiffness, and maybe instability will be there. If you have already osteoarthritis, you might stimulate the osteoarthritis further and further. Pelvic osteotomy can provide you the support, but the incongruency after a radiate cartilage closure is not granted. When we do Pemberton or Dega or Salter, let's say Pemberton and Dega, when we do acetabuloplasty, you follow the patient and you see that the roof will take the shape of the femoral head. This is not happening in those older patients, so you will have permanent incongruency in some of the cases. There is also a post-operative care dilemma. Casting. What cast you will apply for the patient and how for long and for how long. And we listen to the senior surgeons whether we use shorter durations, risk redislocation, or a longer duration and risk almost permanent stiffness in the hip. What rehabilitation program we can do for those patients without the risk of redislocation or fracturing the femur or the femoral neck even. When to do manipulation under anesthesia if you have a stiffness lasting months and months. When to do the contralateral hip. I think doing a 10 years or 12 years child simultaneously, I don't know how to do it, but it's not feasible. And I believe one of the most important factors in operating in a neglected delayed DDH is patient factor. Why this patient? You need to ask yourself why this patient, despite she or he was limping, he was not brought for treatment for those 10 years or 8 years or 7 years. They will definitely have a challenging social circumstances. Either they are illiterate or they are very poor. The family have tremendous number of children. So if you want to rely on your patient or the caregivers for the patient for post-operative care, you need to think 100 times before selecting your patient for this unpredictable procedure. And at last, you need to keep in mind that the outcome of your procedure is not that good, and the need for total hip replacement is almost absolute. So try your best not to burn bridges towards successful total hip arthroplasty in the future. Don't kill soft tissues. Don't leave behind hardwares. As mentioned by Jessica Woodcock in 2013, she showed clearly in 31 hips with retained pediatric hardware that those cases have increased surgical time, increased intraoperative complications like bleeding, fracture, nerve injury, increased hospital stay, and unfortunately increased rate of revision of the femoral stem in those patients. So operate, do clean surgery, and remove hardware, prepare them for total hip replacement in future. I think, Dr. Amna, we can stop if you'd like, because we have taken a good example for cases. What do you think?
I think it would be really good if you start presenting your cases. I know you have 10 cases. I think
Yes.
if we can at least go through the first 5, 6 cases, give us your plan, what did you do? And then we
Sure.
can move forward to Dr. Imran's
Sure.
lecture. And then if we have time, we can go back to the rest of your cases, and then we can do an open discussion between you, Dr. Imran, and any of our senior surgeons who are available in the meeting.
Thank you so much. Okay, so the first case, straightforward. 5 years old, healthy otherwise. She only have hyperlordosis and minor waddling. Actually, the family is educated. They have no issues with their social finance, but they did not expect that the child had a problem. They thought it's a habit initially, this hyperlordosis. Then they did a spine X-rays in her local hospital, and they found this neglected DDH. No previous treatment. So she was operated on the right side, simple. It was placed in, good pelvic osteotomy, shortening osteotomy. She recovered after 10 months, and as you see the shadow of fracture of distal femur, there was fractured distal femur with stiffness after surgery, but she recovered her range of motion in 10 months' time. Other hip was operated. She recovered range of motion after 2 years, and hardware were removed. This is the patient before surgery, and this is her after she recovered from her surgery. Why she has this favorable outcome? Age, open trilateral cartilage, small and round femoral head. This is a very important point to consider. The size of the femoral head, believe me, it will cause trouble for you if it is large femoral head. So small and rounded femoral head. Tunis 4, the rim of the acetabulum was not touched. It is dysplastic, yes, but there is no deformity in the rim of the acetabulum, and the family did their job. They attended their visit, they continued the follow-up, they did physiotherapy at home. That's why she's having a good functional and a good radiological outcome. A unique scenario, 10 years old girl, limping, ligament discrepancy, almost 4 or 5 centimeter, healthy otherwise. Actually, she was about to receive her treatment at the age of 2 years, but a road traffic accident make her an orphan. So the caregivers, her aunts and uncles, they were very reluctant to take her for treatment because she's an orphan. They were very scared to look to cause trouble for her. But when the child reaches the age of 10, she compared herself to her colleagues at the school, and she insisted on her caregivers to be treated. They presented to King Faisal Hospital. We discussed with the family the complexity of this issue, but I was not, let's say, feeling safe to operate on her at this age with this radiate cartilage affected. So I sent her to physiotherapist in her city for a couple of sessions, see how serious is the family to attend and how cooperative the child is with physiotherapy. And I received a very positive report. She was, this is her CT scan. I would say reasonable acetabulum, but radiate cartilage is doubtful. This is her surgery. So we did the femoral shortening, we did the pelvic osteotomy, and she was stable. Even in neutral position, she was not redislocating because the acetabulum rim was okay and the femoral head was reasonable. This is her after surgery. This is 6 weeks post-op, 3 months post-op, and you will see what is expected. Stiffness. She's tilted. You have a relative view. This is stiffness. This is 1 year. She was doing physiotherapy despite that. Yani. And this is her almost 2 years. Stiffness started resolving, and we took off the plate. This is 3 years after. There are some avascular necrosis and changes in the femoral head, and she's happy now. Ligament discrepancy is about 1 to 2 centimeter. She's stable on her gait. What is with and against this case? Age is not in favor of good outcome, almost closing radiate cartilage. She's unilateral. This is in her favor. Tunis 4 with deep acetabulum. Query there was false acetabulum urging surgery. There was no osteoarthritis, and family and the patient were the key for functional recovery as such. This is a 9-year-old girl with a right DDH, Tunis 3. During intraoperative exam, after we did the open reduction, she was reducing with no tension because it's Tunis 3. So we decided not to do femoral shortening osteotomy. Is this right or no? She was very stable, despite she was Tunis 3. This is her after surgery, 6 weeks post-op, 12 weeks, stiffness, 6 months, Stiffness 1 year post-op, 2 years, 3 years, 4 years with AVN. This is 5 years with some acetabular dysplasia as well. So this is her before surgery, and this is her after. What's in her favor and against? Age, unilateral. She's 23, not 24. So there was issue with acetabulum. Maybe this explains why the acetabulum retained its dysplasia. There was no osteoarthritis. Is femoral shortening osteotomy even if that you don't have soft tissue tightness with reduction is indicated to protect the femoral head? Maybe. I think the more senior colleague can answer that. I think her prolonged stiffness was related to her social challenges. She recovered almost 3 years after surgery. I think I will just jump those cases, Dr. Amina, and I will give some conclusion because I don't want Dr. Imran to wait a lot. So in conclusion, from these journeys, sorry.
Thamar, please take your time. I am interested in these.
You want to proceed, Amina? We have time.
We still have time. If Dr. Imran is happy, we can still go through your cases.
طيب. I would go for this. I would go for this, and maybe the one before because they are interesting a bit. This patient is unique actually. 8 years old boy with bladder extrophy, diagnosed to have I would say high dislocation, but not cleared for surgery because he was leaking through fistula around the hip, and the fistula closed at the age of 8. What to do? This is bladder extrophy with neglected DDH, to leave him for arthroplasty or to operate. Actually, when we did his CT scan, he seems to be, his bone age is younger than his age. His radiate cartilage is widely open. He's 24, but if you see this 3D cuts and this axial cuts, there is retroversion of the acetabulum. It's actually the hemipelvis, the whole hemipelvis is retroverted with no posterior wall. So we expected difficulties with stability. You see, there's no posterior wall here. So we prepared K-wire before we start. So we operated in him. Yes, reduction was easy. Pelvic osteotomy was easy. He was very flexible when we flicked the acetabular roof, but he was profoundly unstable. The moment you flex him beyond 30, he was dislocating immediately. We put a K-wire. We removed it in 6 weeks' time. This is him after 6 months, 1.5 years. And this is him after removal of plate, 3 years post-op. This is him before, and this is him after. I think the only thing in his advantage was the younger bone age in this child. He behaved like 6 years or 5 years of age rather than 8 years of age. This is very interesting case. 8 years old girl, limping and living discrepancy, challenging social circumstances. They are living from far, and she presented with this. This is 23 with a very deformed femoral head, blunted acetabular labrum or blunted acetabular rim. What to do for this? She's young, she's limping. I think she will have osteoarthritis soon in her life. So because she's unilateral, we decided to go. This is the CT scan, and you will be interested to see it's not the rim that is affected only. It's even the posterior wall is almost absent. So theoretically, we are facing a nightmare. There will be global instability, and the patient will suffer, and any osteotomy we will do will not be sufficient to provide the stability. We lose K-wire, she might redislocate after removal of K-wire. This is the patient intraoperatively, and you see the ligamentum teres was intact. And this is the femoral head. You see, it's a donut shape, very irregular, but there is no osteoarthritis in the femoral head. Surprisingly, that there was stability in this hip before osteotomy, and after we did the osteotomy, you see, we put it in neutral position. It's not redislocating. Even in adduction, extreme adduction, this patient was not redislocating. This is him after surgery, 3 months, 8 months, 1.5 years. You see, is it AVN? Is it the femoral head deformity at initial stage? We don't know, but the femoral head was very, very awkward to start with. 3 years, 5 years, and ligament discrepancy is about 1 centimeter. So this is the patient before surgery. This is the patient after surgery. Is it in favor of arthroplasty or no? I think Dr. Imran can comment later on. What was in favor of this patient? Open traumatic cartilage. Against, definitely is Tunis 3 with issues with acetabulum. The femoral head was a big concern. But I think the idea to take from this case, the preoperative radiological evaluation is not, I would say, conclusive. You might have a poor CT images, but good clinical stability, as in this case. I will show you another case. This one, sorry for حرقنا الفيلم يعني معلش. This one, 8 years old boy from educated family. According to them, he was walking normally. Till 1 year or 2 years ago, he started to have limb with activity. Then it progressed. Was he having Tunis 1? Then it progressed to Tunis 3. I have seen 5 cases like this. The family denied any limping in early childhood. Anyhow, he came with this. Reasonable femoral head. Acetabulum is not bad. We did not do حتى CT scan because it looks nice. It looks nice. Tunis 2 to 3. Let's do. He was reducing very easily, even on general anesthesia. There was no source of tissue tension, just minor adductor tightness. So we did for him open reduction. We put the femoral head in the socket. It was unstable, redislocating very easily. We did the pelvic osteotomy. We reassessed the stability after osteotomy. Again, it was unstable. So we decided to put K-wire. This is him after surgery. This is him after 6 weeks. We removed the K-wire intraoperatively, I mean in the OR room, and we adducted the hip. It was stable. We applied broomstick cast. He came back at 10 weeks for removal of broomstick because we thought that this is an easy hip, not that difficult. Let's remove the cast in 10 weeks. We'll cut it short. يعني instead of 6 weeks, let's do it 6 weeks and 4 weeks broomstick cast. He came in 4 months with this dislocation. So I don't know صراحة what to tell the family. We all were shocked. It's lateralized, shunt line disrupted, so it's a complete dislocation. We followed him up. Sorry. The family are educated and they asked me clearly, do you grant a good results or no? I said it's a revision in older age. I can't grant best outcomes. So they decided not to go for surgery. And this is him 1 year, this is him 2 years, and this is him before and after. What is with and against this patient? Actually, he was appearing as an easy case, younger age, 8 years, شوي. Now it's not 11 or 12 years of age, open traumatic cartilage, but it's Tunis 3. And slightly deformity in the femoral head with no osteoarthritis. So treatment of neglected cases is not predictable to large extent. So the conclusion from this journey is the following. Surgery for neglected and delayed DDH is complex and unpredictable. Success and failure in this journey are multifactorial. Caregivers, when you consent them, they should be prepared for high failure rates. Consider age and puberty, closure of traumatic cartilage. Consider acetabular, femoral head morphology, and consider 100 times patient factors. Thank you so much.
Allah يعطيك ألف عافية Dr. Thamer. This was really a great presentation, and I think if you have another 10 cases, I'll be more than happy to see them and learn from everything you have to teach. So we're going to open the floor if anybody have any questions before we move to Dr. Imran's presentation. Please, if anybody have any questions, just put them in the chat and we'll try to answer them. Dr. Imran, do you have any questions for Dr. Thamer?
I would give the audience first. I have lots of questions for him, but and we're going to discuss a little.
I have a question. If I am a junior surgeon, just started my career, and I got one of these cases, do you think it's better? Like I have a 9-year-old kid with a DDH, or like even an 8-year-old. Should I operate on that kid or talk to a senior surgeon to be with me or just refer this case to somebody who's an expert?
I think the best scenario, you need to do them because definitely you will be able to do them. If you do the younger age group, you can do the older ones. But having a senior one around is of great help. When I started to do them, I was not alone. I was with Dr. Wade. We did together so many cases. Then a gradual weaning happened. To me, I think it was the best healthy environment for training and practice. But you see, if you are alone in a hospital with no senior people around, because you see, you need someone to tell you it's not your fault. You will kill yourself if those patients get failed. So
Yeah.
you need senior people around Amnet to help you. I think from technical point of view, anyone who can do a 3 or 4 years uh, of age, 24 highly dislocated ones, he can do those ones. But I believe in the first two cases, better to be with someone senior who's expert in doing them.
Okay, so we have a question from Dr. Shaima saying, for the last case, would varus derotational osteotomy help if you did the revision? And would you consider them before the K-wire? Like, would you do varicose femoral varus osteotomy rather than putting a K-wire to add stability?
والله دكتورة شيماء أنا I'm not sure what happened to this hip. Why this hip was unstable. Soft tissue balancing was excellent. We do actually popliteal angle to assess is there a tension in soft tissue or no. There was no soft tissue tension. If I do femoral shortening or varus, tissues will be redundant. It will not create, I would say, a joint action force or let's say a stability in the hip. When I have been through that. I have shortened a patient more than required, and he become profoundly unstable. So if you have a soft tissue tension that is normal, not affecting your stability, don't do shortening. Um, is there a rotation issue in this? Was it femoral anteversion that caused instability? We assess femoral anteversion inside. It was not significant. I think what happened to this patient was incongruency between the acetabulum and the femur. Could the period of immobilization was also additional reason? This hip might need more time for it to get congruent, to get adapting. I don't know صراحة.
Okay. But at least I know some surgeons, maybe not in Saudi, they don't even do broomstick casting. They do open reduction, they just put the hip spica in 6 weeks and they just take it off. So being in a broomstick cast for 4 weeks, I think, is relatively good, I think. But maybe in these cases, you want all the stiffness. Another question by Dr. Yasser Khlaifi saying, do you do CT scan for all your neglected cases or you only do selected CT scan?
Well, I actually this question I discussed it with Dr. Yasser before because Dr. Yasser also is having an experience with redislocated cases from outside. He's revising them, and we discussed this CT scan rule in doing revision surgeries or neglected delayed cases. I don't think we agreed actually that CT scan will not prevent you from operating. Maybe will prepare you more, but as you have seen in that case, Amna and all the attendee, all the poor prognostic factors were there in this patient. Acetabulum was damaged, femoral head was damaged, but stability was there. So I think it will help you in planning and prepare you, but will not definitely يعني prevent you from surgery. Unless طبعا revision cases may be more complex than this because there might be a bony insult inside the acetabulum, so you might want to see if there is ingrowth to plan also your act. But I think most of the findings you will see in CT scan, you will see it intraoperatively. And I don't know any of the senior surgeons whom I trust in their opinion, and the CT scan prevent them from going in to do revision or to do a neglected case.
Okay.
Maybe prepare you more, لكن it will never prevent you. يعني.
Okay. So another question, when do you decide to do K-wire or to insert a K-wire?
أنا after I do the open reduction, دكتورة آمنة, and I balance the soft tissue, I make sure that there is no soft tissue tightness. I did the required femoral shortening / derotation osteotomy. I assess the stability. If it is stable now, definitely there is no K-wire. If it's unstable, I will not put K-wire. I will do osteotomy because the stapleplasties, whether Pemberton or Dega, provide a tremendous coverage, lateral and anterior, maybe relatively posterior if you are doing a San Diego extensions. So after the osteotomy, if there is a residual instability, I don't trust the cast to keep it. I put this K-wire.
Okay. Do you try to check where is the instability? Because, sometimes if you do flexion and then it dislocates, maybe there's a bit of a posterior under coverage. So you just move your graft and then reassess. If you do all of that, then you decide to do KRs. I know in DDH, usually it's anterolateral, but I know that sometimes you get the very unusual cases.
We do analysis. We try to recognize where is deficiency, Dr. Amna. Like, believe me, if it is posterior deficiency, you will put K-wire. No osteotomy in pediatric orthopedic can replace this posterior deficiency.
Okay. Another question by Dr. Al-Murshid saying that do you agree with Dr. John Wedge's cutoff age that he says for unilateral you can do it up till 6 years of age, for unilateral up to 9, and for bilateral up till 6? Like, what is your experience cutoff age for operating on a patient, unilateral and bilateral?
Wallah, I think it's so many factors. I mean, it's not age. And as you have seen in those cases, some of them, they are 9, but they look younger.
Okay.
No author mentioned bone age for children. They said upper trachea cartilage or closer trachea cartilage. I think so many factors. It's multifactorial to decide. I believe if you encounter a patient who's almost closing trachea cartilage with severe deformity in the acetabulum, severe deformity in the femoral head, don't touch him, please.
Okay, fair enough.
You will not succeed. Yes. But if you have, say, one factor, you can يعني, cover for one factor. And all the time, those patients, they are unique. They have social challenges. Negotiate this.
Okay, perfect. Would you still do the reduction in a case of early arthritis in an older age?
I have a couple of cases. I did not present them in this presentation. Unique حقيقة يعني a 7 years old child, tonus 2 to 3, يعني high tonus 2, and she's having a big cyst in her acetabulum.
Okay.
What to do? I can't leave her for Dr. Imran. She's still 7 years of age. She's limping significantly. So I went in. I did shortening, the rotation, pelvic osteotomy, good coverage, and the cyst disappeared.
Okay. Nice.
For how long it will last, I don't know. But I believe if I lift her, she will definitely have a very progressive osteoarthritis.
Okay. We have another question by Dr. Walid saying, when would you do a triple osteotomy? Or if you think you need the triple, then they're too old, just leave them be?
Yeah, maybe. But I believe Dr. Walid and I think triple pelvic osteotomy, I have little experience with it. But I stopped doing it because most of the real DDH ones, in Saudi Arabia at least, they are very dysplastic. If you have acetabular index exceeding 50 degrees, no rotational osteotomy can give you stability. Either you do acetabuloplasty or you go salvage with Chiari and shelf. If you rotate this extremely vertical acetabulum, you will not get stability with this. Chiari, it has been mentioned by Klesic group. It's mentioned in older patients to provide coverage and stability. Honestly, I don't have experience with it. Doing it in primary cases. Never been operated before.
Okay. We'll take one last question. What's abductor muscle function in this case? Dr. Khalid Zaghloul is asking, what is the condition of the ligamentum teres on those cases? Were they intact or not?
Mostly, if they are tonus 4, mostly ruptured.
Mostly
Ruptured. You don't see it in those older group. But that patient with deformed femoral head, I think ligamentum teres was the reason for this unique deformity. For
Okay.
9 years old of age, subluxated or almost dislocated, with intact hypertrophied ligamentum teres, you get this beveled or bullet-shaped femoral head.
Then his other question would say, what is your thoughts about ligamentum teres reconstruction? Because I know some people try to do that using like sometimes with endo buttons when you have a lot of
نعم.
instability.
Yeah.
Have an experience with that? What are your thoughts?
I don't have, والله. I think Dennis Winger, people from San Diego, they talk early about using ligamentum teres as a stabilizer. And recently they are using tight ropes to recon this kind of ligamentum teres stability, but we are fine with it without it. يعني. Stability wise, we don't have issue, and our numbers is matching more or less the same as the international one without it. يعني.
Okay. I think that is it. If we have some time later on, we can come back to the rest of the questions in the chat. Now I would like to present our second speaker for today, Dr. Imran Elias. He is an orthopedic surgeon at King Faisal Specialist Hospital. He's a professor at Al Faisal University. He has an experience from around multiple continents, Australia, the UK, US, and we have been lucky to have him here in Saudi Arabia for the last, I don't know, for as long as I remember, doing all sort of complex cases. He's not the regular arthroplasty surgeons. He's the to-go-to when you don't know what to do. We are very happy to have you here today. We look forward to hear your thoughts on what are the things that we should do and what are the things we should not do to make your life easier to get our patient to the best outcome that they deserve.
Thank you very much, Dr. Amna, and thank you very much, my orthopedic colleagues, Dr. Thamar, my good friend, Dr. Musa, Dr. Talal, Dr. Nizar Hamdi. We have a very elite faculty there, and I think it's a great time to especially thank Dr. Thamar for his innumerable efforts and what he's done for the kingdom, for our children here. So I really wanted to say that for a long time. So thank you very much, Thamar, for all the efforts that you put in. You are a legend.
You are.
Thank you so much, Dr. Imran.
So I would I'll just go through with this. I'll share the screen. I hope it's you can see it.
Yes, we can.
You can. Okay.
You can just hit play.
Play. Okay. Let's see this. Okay, here, and I'm just gonna bring this down, and I'm gonna play this here. Is this clear a little bit?
Yes, it's clear.
Okay, great, wonderful. So once again, it's really a privilege and honor to be here and talking in this wonderful webinar. I've really enjoyed the talk of Thamar, fantastic cases that I've seen, and I've always been admiring him for the last so many years working with him here. I am going to talk about late DDH in older children and adolescents. And being in King Faisal, we were privileged to see so many patients referred to us from all over the country. And now we have got some areas where DDH is so much prevalent, especially in the south. We get a lot of patients from there, and we've been treating them for a very, very long time. And adolescents, as we know that the World Health Organization classification from 10 to 19 years, now we have the early adolescents, the middle adolescents, and the late adolescents. And fortunately, we pick up these DDH cases at the time of the birth, and many of them are managed. But nonetheless, we see them frequently, maybe in early adolescence or any of it this time, with either the complications like the avascular necrosis or chondrolysis or osteoarthritis, that we can see them at any of the stage. And at that time, it becomes kind of a dilemma for us as to what is the best way to manage these patients. And actually, this is excellent to sort of have a collaboration with the pediatric and the adult reconstructive surgeons to manage these patients together. And I am fortunate because Thamar is there and other colleagues are there. Dr. Musa also has joined us now, fortunately, so we can discuss these cases and make a joint collaborative discussion. I think this is extremely important. So dysplasia surgery in childhood and adolescents, the first line of management, I would still say that acetabular osteotomies. And why I would say is that, of course, again, it's dependent on how the hip looks like. As Thamar mentioned again and again, you've got to look at the morphology of the hip joint, look at the acetabular index, the central edge angle, and see the congruency of the joint. And if you feel that all these are in place, then I think acetabular osteotomies still have a place, and we have a 10 to 15 years survivalship of about 80 to 90% of these cases. And what the osteotomies do for us is that they give us a very good established shape. So at 30 years of age, if the patient has had to have total hip replacement, then it's a straightforward surgery. You just have to put in an established shell and you're home safe. Because you've got a very good coverage. You don't have to rely on augments, on bone grafts. And then, of course, the longevity of that established shell becomes compromised when you have to do all these things. But on the femoral sides, of course, there is a retained hardware, which becomes a problem for us. I have been sort of sweating, digging out hardware from the femoral proximal femur, with these plates just buried inside, and we take a lot of time to sort of evacuate those plates. So it's a wonderful to hear from Tamer that he is very careful to remove all this hardware. And if you have a proper dissection done, this also gives us a very good sort of a route to go inside and a planes to sort of dissect on this. But nonetheless, these deformities which you develop after the osteotomies can become cumbersome for a stem placement, because remember, the stems are all straight. They're not sort of curved or bent. So you need to have a very straight proximal femur to have a good straight shot at it. So why we delay total hip replacement? I mean, traditionally, you have the open growth plates. The implant positioning becomes suboptimal over time as the patient grows up. These patients are very active, very young patients, 10, 11, 12 years old. They want to jump around. They want to play with their peers and relatives and friends. And of course, you can't deny them this. And with this activity, they put much more load on total hip replacement. And of course, theoretically, then you will need multiple revisions. And as an arthroplasty surgeon, I'm not looking for my surgical operation the next day. I'm actually bringing a journey for these patients. I'm thinking for how long and how to do these things that would last, if not lifetime, many, many good years for them, and make it easier for this journey that this patient is onto it. So this is like a real journey onwards. The surgeries, of course, are technically demanding. And osteotomy and fusion are viable options with surgical experience and stage of arthritis. If this is a stage of arthritis which is early, then of course osteotomies are very helpful. Fusion, I would take it out of the cards. Days gone by, fusion was accepted, but now I think the fusion is not on the table. Why do early total hip replacements? So if you see the early total hip replacements, of course, pain, stiffness, leg length discrepancy, loss of function, loss of normal biomechanics, overload on other joints, and patients prefer motion and not fusion. And you see what happens. One joint, if it is affected, it destroys many other joints. And what it does is one hip will affect the knee on the same side. It will affect the spine. You can see the top picture there where there's pelvic obliquity, and then you develop compensatory scoliosis. And these patients become very handicapped. They become socially misfit, they become introvert, and they become psychological issues, not only for the patients, but for their parents, because they become very, very reserved. They're not enjoying the activities of normal life, because these are young patients. They want to play around. You don't want to go to a school where you have pain in the hip and sitting in the corner while your friends are playing outside in the garden. So they lose on the milestones. And the other joints get loaded and the spine gets affected. Look at this X-ray on this side. If it's there, you can see that this compensatory scoliosis is developing. And many of these patients end up visiting spine surgeons and I've seen some of them actually being operated upon. And I think the problem really is the source is the hip joint, which is causing this problem. So for the residents, the DDH classification that we frequently use in the adult practice is the Crow's classification. We have the Greek classification, but this is the one which most often we use. And I think for your exams also, you would probably may get a question or two out of these. So the first is subluxation, which is less than 50%, but it is the height of the pelvis, which is, I think that you should take, and it's about less than 0.1% of the pelvic height. Type 2 is 50 to 75% subluxed upwards with 0.1 to 0.15% of pelvic height, and so goes 0.15 to 0.2. And then finally, you lead to a complete dislocation, which is greater than 0.2% of the pelvic height. And this is how you draw it. So you draw a line on the inferior part of the ischial tuberosities. You choose the highest point of the iliac crest, and then you have this pelvic height. And of course, then on the other side, when you have a dislocated hip, you can draw a line which is going from this transverse line to the head neck junction, and then you calculate the difference and the ratio. So if it's 0.1%, it is grade 1. If it is greater than 2.2%, then it is 100% dislocation. And this is how it looks like. So you see how gradually the head drifts up. And finally, in the grade 4, there is no contact with the acetabulum, and the hip is completely dislocated femoral head. So what are the surgical challenges in children? And we are talking about cohort of the patients who come in the gray zone, where they've had these non-operative measures and they've had some operative measures as well, but it has failed to relieve the symptoms. And they have come to a situation where they are in a very tight spot, where they're looking for a quick resolution of their symptoms and back to their lives. These children have altered anatomy, dysplasia, deformities. They have maybe retained or buried hardware. They have small bone size, and they may need customized implants. They may need femoral osteotomies, and then there are growth considerations because the GT may overgrow, and then this could lead to shortening of the abductors and gait disturbances. Remember, when we're doing a total hip replacement, it's not just the x-rays that you're looking at. You are actually looking at the soft tissues, which I always tell. And many of the times this is neglected. I mean, we focus too much on soft tissue releases and balancing in the knees, but we forget about the hip, where we actually need to do that also. So what are our problems with these younger children? The problems are, of course, they have disuse osteopenia, but they're very young. We need something which can last them for good many 25, 30 years. And the recent technology that we have is the trabecular metal technology. And this is very close to the bone. So we have an excellent bone ingrowth into these implants, and you get excellent stability and very good long-term results, which we've seen in the adult population. And we expect almost the same in the pediatric population. So this is what takes care of for the longevity of the prosthesis. The small canals, we deal them with a number of prostheses which we have in hands. We have the DDH prosthesis. You can see the Wagner cone stems that we have at the top. The smallest size is about 13. But we also have, and in my practice, we've done cases who have less than that. So we've used Charnley DDH stems. They are cemented, but they come in size 5 and 7.5, and they can tackle almost all the small ones. And if you're very small, then customized implants are there. How do you deal with small stabili? Now, this is a problem. Now, the problem is that the liners that you place in, these poly liners, they're very thin because the shell size is small. If it's 40 millimeter size, the poly liner becomes very thin. So here we have ceramic liners for them. The newer generation ceramic, which is the Biolox Delta, I think they are excellent. And I think these are my go-to prosthesis, especially when we are dealing with very young patient population, and we'll show you some cases for this. The instability, of course, the instability in DDH, not just because of the anatomy, but also because of the soft tissue contractures can be a problem. And you have a dual mobility shell, which you can see on the right side in the lower bottom corner. And that can give you an excellent sort of instability solution if you feel that is the problem. So what do we have in literature? I mean, literature is so much varied, and it's very difficult to sort of pick out all of these here. So we look into the meta-analysis. And here this Hernigu has published this. This is a very recent one, December 25. He looked at this 25 years literature review. And if you see the 3,106 primary THRs performed, main indications, however, 35% avian. Now, this becomes a heterogeneous population, dysplastic hips 33%, non-cemented fixation predominant. And that's what you would expect because, younger patient population, you need biological fixation in these. Overall revision, 8.2%, loosening 53%, wear 12%, but 5 to 10 year survival still 91.7%, which is comparable to adult benchmark. And these are the liners that were used, and you can see that from 2000 onwards to 2020, the liners and the bearing surfaces, which was ceramic on poly, has actually climbed up quite a lot because you have highly cross-linked polyethylene with vitamin E infused in many of these cases. And these give you an excellent long-term results. Metal on metal, of course, it's gone down, it's out of the shell because of the number of problems they've had. Ceramic on ceramic, it's not picked up as I thought, but these studies, which were the previous ones, were using Biolox Forte, which was the older generation. This was just alumini. But right now we have Biolox Delta, which is the alumini composite and dipped in zirconia, which gives excellent wear results. And I think fracture and squeaking is much less, and the stripe wear is also almost unheard of it. So this really is a hard-bearing surface, and I think for smaller shells, this still is a very important tool to have. This is another systematic review by the Elena Hirfeno, and they looked at 25 studies. 1165 primary THRs. Again, the indication here was juvenile inflammatory arthritis, but again, a very younger patient population. Non-cemented fixation, again, loosening about 15% in 10-year survival, which is 85% and close to the benchmark. Hong and others, this is a single pediatric THA series, 92 hips, 11 to 21 years, mean age 16 years. So if you look at all these series, the mean age is coming around 16, 17, 18. This is what it's coming out. But when you look at 14 years or less, we don't find too many of literature, too many of papers written on it. You will just find some case reports that are written to it. Their mean follow-up is less, but again, the survivorship is close to 98, 99%, which is excellent. So I think as we go forward, the more long-term results are coming around. As Tamer mentioned, there are results which are about to be published, which is looking at a series of 25 years plus, which is very good track record for these cases. I will go with some of these cases. Now, these cases that I'm going to show are cases who are younger cases. This one has idiopathic chondrolysis, an 11-year-old girl, inability to walk. They become really crippled, and it's severe pain, and they develop flexion contractures. When they develop flexion contractures, it becomes an extreme big problem. This is what the radiographs look like, and you can see that the pelvic obliquity starts to tilt up, and the whole spine starts to have this scoliosis and compensatory scoliosis, and they are extremely painful. I think this is just a video here. If you can see, she can barely take a step. That's all what she does. You can say that she will not be going to the school. Once again, she will just be staying around in her wheelchair. That's what she's comfortable, because she is shying away. She doesn't want to have these activities. So, I mean, this is, for me, straightforward total hip replacement, and that's what she gets. This is the straightforward total hip replacement because, I mean, this is idiopathic chondrolysis. We didn't have to stabilize the screws. She got a ceramic head and ceramic on ceramic. And this is her. She's about, say, 3 weeks or 2.5 weeks post-surgery. Now she is able to weight bear easy, and you can see she's comfortable. She is not like bothered. You can see it on the face. You don't have to sort of, even examine her. And this is her in about 7 weeks, and you can see she's still got a little bit of lurch, but very comfortable. And she's walking. She's gone back to school. So, she's restored. The life has gone back to her, and this is what she needs. This is a 14-year-old girl, and Tamer probably would be knowing about her, DDH with AVN and sublux step. Most of the sublux step goes and hinged up, and they get this complication of avascular necrosis. And that becomes a problem because as the hip gets abducted, this is how they look like. The whole hip, the leg gets externally rotated because the hip is externally rotated. And that affects the knee because the knee becomes valgus. And the foot becomes also a problem. So if you see the walking here, you will see how she puts the foot. Look at the foot. The foot also goes in pronation. Once again, the foot goes into pronation, and she cannot sort of walk unless and until she uses a cane. So this is what she uses. It's pretty comfortable, but not the best out of it. And she gets a total hip replacement, which is straightforward. We use a Wagner cone stem, and this is her at 6 weeks. And she's a happy kid, gone back, and she's enjoying her life. And this is what we want for them. So quick fixation and a good solid forward here. This is our case 3. This is recently done. I think this we done a couple of weeks ago. She's a 17-year-old girl, DDH grows 4. This is how she comes. And we've seen a lot of cases from Tamer about these. Look at what happens to the femoral heads. As they grow up, the femoral head becomes smaller and smaller. And the CT scan shows that, of course, this is dislocated completely. And what happens is this femoral head, as it dislocates, goes up superiorly and posteriorly. It starts goes through pierces the gluteal muscles and kinds of make a pseudo joint up on the iliac wing. And that becomes painful. And look at the acetabular down there. They're just triangular shaped. And they are there because they've never been used. They never grow up. They're like this. So she is 17 years old. And the question is, how long were you going to wait for it? You can go and send her to physical therapy. This is not going to help, to be honest. Physical therapy is not going to help because it's going to be very painful. She is not going to develop muscles at all from this. And the other problem that she is developing is this. Have a look at her spine. All our patients who get the problems in the hip, they get a full leg spine view and the full extremity view. See the spine in the AP view, it's all dead straight, but look at the lateral view. She's developing hyperlordosis. The pelvis is forward flexed. When forward flexed, it's like an inlet view. Look at the obturator foramen, very wide. I apologize if the pictures are not very clear, but you can see that you can make an idea about how the pelvis moves. And this becomes technically challenging because the anteversion here, you have to adjust. It's not like the normal hips that you put a regular anteversion to be okay. Here, if you antevert the acetabular component too much, you may have an anterior dislocation in these cases. So here, in these cases, you, of course, have to do shortening osteotomy from the get-go. There is no point doing anything else. You have to preserve the proximal femur as much as you can because that's the good part of the femur that you have to load. All the soft tissue attachment is on the proximal femur, your abductors, your iliopsoas. So all of these are there. This is what it looks like. You can see this. But be careful because in these cases, they're all dysplastic. So dysplastic hip comes with dysplastic nerve. So if the femoral nerve is equally vulnerable, as with the sciatic nerve. The arteria profunda femoris is riding up high, so be careful with that also. And you can see that this becomes a complex problem. When you bring it down, you will have to stretch a lot of these muscles and ligaments. Now, this is the intraoperative picture of this case. I don't have the arrow and pointer to show you, but where the finger is pointed, that's the distal part of the femur. You have a middle fragment, which we have devised this osteotomy that we do a longitudinal split, which is the split which is in the sagittal plane, so that it opens up like a book. So you retain the soft tissue attachment in this middle fragment because you're going to put this middle fragment back, close it on a book when you reduce this osteotomy. The proximal femur, you can see that this proximal femur is covered with the gluteus medius and other soft tissue attachment. This is a lateral approach that you're seeing it. And I prefer the lateral approach just because, there is a problem with these patients. The instability is higher. Although you can use a posterior approach as well for these cases. It's not a problem. But I think the lateral approach, I'm a little bit more comfortable because you get more stability for these cases. And this is the middle fragment. The middle fragment, which is isolated, is actually attached with the gluteus max. So what we do is, and we published our technique in the Journal of Surgical Techniques, we rotate this fragment with the gluteus max and put it on the lateral aspect of the femur. So rather than being an extensor, part of it becomes an abductor of the hip joint. And then when you put down the hip joint, so the hip is in, you can see the osteotomy just where the suction device is going on. You can see the osteotomy is interposed. This is a transverse osteotomy, and I think this is better because you can rotate the fragment. They have anteversion problems, so you can put it in the right version that you feel at the time of the surgery. And then on the table, you can check them and see the stability, how the stability is. You can sort of move them around, make sure the osteotomy doesn't move at all. Because if it moves, you can fix it. Fix a plate, put a plate. I would put a plate on this. Once you're satisfied that you've had this, then you can take your fragments, the one that I showed you, and then you can wrap them back on this osteotomy. It does two things. It brings a lot of blood supply to this, and it also aids in healing of this. And this is how it looks like. So you can see on the right side, this dislocated hip, you bring it down to the normal position. So you restore the biomechanics of the hip joint. And with this process, we've done a lot of this. Our series actually expands. We need to publish this series. It's probably more than 100 hips that we've done like these for the osteotomies. And most of them, we've had our share of complications, which we can talk about at a later stage. But most of them have done very well with very minimal lurch. Now, if you have a case like this, and I think this was done before by our pediatric colleagues, they've done the osteotomies, it becomes very easy for us then. The coverage is very good. We don't have to put any bone graft. You just have to ream the acetabulum and just put them because the socket is deep enough. And they do extremely well with this. And this is another complication. This patient had a DDH, and I think she had an osteotomy before, but went on to avascular necrosis of the hip joint. This becomes like what I call them as a plastered hip. Because this kind of a fusion, it's like pseudo fusion because there is no head, there is no offset, and you really need to develop that offset to give these abductor muscles a chance to function. That's another thing. A lot of hardware is there. Again, it's the same complication, and sometimes they become very difficult because they become a pseudo joint which is extending even down. And here you have to you study the CT scan very well, take out the extra bone formation, and then do this. Now, when you put this hip and of course, you put the hip joint, you are actually stretching the sciatic nerve. So we have the nerve stimulators in the OR. We always isolate the sciatic nerve. We always examine it with the nerve stimulator, make sure that it is functional because very easy. The nerve can be dysplastic in these cases. And when it's plastered like this, the nerve is not moving. Remember, with the hip joint, when the hip moves, the sciatic nerves move at the back. If the hip is fused or a pseudo fuse, the sciatic nerve doesn't fuse. It kind of freezes. So when it freezes, you really need to sort of make sure that when you're lengthening, you have an intact sciatic nerve, And that's how it remodels, and becomes pretty good. This is another case. This is a recent case, and I did a dysplastic hip, and she cannot walk. She is, I think she's 11, big 11, fortunately. She's very difficult to walk, and she again is not going to her school, not going anywhere, And we discussed a lot about this. We had sent her X-rays outside also. So I discussed with my colleagues as well, and then we did the total hip replacement. This is her. She is actually only 2 months post-surgery. and she's dead straight almost. You see, so these children actually sort of one advantage with them is they recover very, very quickly, and sort of they have a very good gait, very good range of motion. Have a look at this case. Now, this is another dysplastic hip, and this is the X-ray I showed you first. And what this hip is doing is, look at the pelvic obliquity. The pelvic is oblique, and you can see that she's developing a scoliosis on the AP view. And here she is. So she ends up having a total hip replacement. And look at this is in the middle picture is, and the pelvis is now getting back to a neutral position. That's where it's on the left side, and at this stage you would say probably, oh, she may need some surgery for the spine, but no, do a total hip replacement and set the biomechanics right, and look at what has happened to the spine. The spine is actually shifted back to normal. You don't have to sort of have an unnecessary spine surgery when the problem really relies on the hip joint. So the message really from this case is that you've got to fix the hip. I think that has to be done first. This is another case, of course, bilateral, and of course, not that high riding on the left side, so very straightforward. On the right side, of course, we had to do a total replacement, and you can see the very small shell. That is a problem, and in our practice, we have revised these polyliners because they've worn out. So I've been long enough here, and so they've returned back to me, and we've revised almost 5 or 6 of them with very small pulleys, because when we did this, the shell size was 40 or 42, and this is a problem with. That's why the failure rate is higher, because if you have got very small shells, they wear out, especially with the metal head. Now we have the ceramic head, but I tell you one of the advantages that I saw. When we go again for the revision, it is not that it is everything is in place. The offset is maintained, and it's easy to get the shell out. And we do a reverse reaming, make a bigger shell, and then we put a ceramic and ceramic. And so if we hadn't done this, we would have more trouble to sort of do this. So revising this was much easier, in my opinion, because the biomechanics is already there, everything is restored. And this is the other hip. We do this, and look at the osteotomy. The osteotomy is very well healed, and she's solid and doing well. Now, if you get a case like this where you have leg length discrepancies, I mean, in these cases, as Thamer mentioned very rightly, many of these unilateral come because they want to have a leg length discrepancy sorted out. So you've got to be very clear to them that leg length discrepancy is not the aim or objective of this procedure. This procedure objective is to get rid of your pain, get the biomechanics restored, and later, once the residual leg length discrepancy is left, we send them to Dr. Tal to do the lengthening, and he's slick at that, so he can actually manage, and he can fix these leg length discrepancies, and it's easier for him. So if you see the case like this, you can see that this is now a case with a deformed proximal femur, because an osteotomy was done for him, and now we have a situation because there is no GT, and you've got to manufacture a GT. So now you would have to devise an osteotomy where you can put it up. You can see this is how it looks like. The great trochanter, not really good. In these cases where we feel that the abductors are really weak, we tend to actually try to fix them with a technique called the Leo Whiteside technique. I don't have enough time, but maybe at another topic we can show that to this. This is a soft tissue reconstruction around the abductors to actually strengthen. This is the transfer of gluteus max and iliotibial band to the greater trochanter to sort of give them the effect here. And this is the surgery, just putting them back and trying to devise that greater trochanter in place. So in summary, I think total hip replacement is a very effective procedure. I'm biased because I'm an arthroplasty surgeon and I've dealt with a lot of these. I know that we have complications, and this is technically demanding. There is no doubt it is. It needs a lot of patience. It needs proper planning, but it is nothing to be shy of, because this will give relief pain. It will improve their gait. It will restore the biomechanics and function, and will prevent their spine and the other joints from deteriorating. The revision rate is higher, no doubt. There are some complications, but these complications can be managed. And I think the pros are much better than the cons. And I think that total hip replacement is here to stay. And I think the indications for total hip replacement in the younger patients is going to actually increase and become even more, because it's a straight shot at these. And that's probably the best solution for these patients. I thank you for your attention and open to your questions.
Thank you very much, Dr. Imran, for this great presentation. I was actually very interested, and I could listen till the end, because usually with arthroplasty, my brain does not tolerate it very well. So thank you very much for this presentation. If you guys have any questions, please post them in the chat. And while they do that, I have a question for you. So, you know that a lot of pediatric surgeons try to do some salvage procedures to try to buy the kids some time, such as a fusion or a pelvic support osteotomy. What are your thoughts about that? Do you think it's better for us to do it, or just leave it be and you'll deal with it later rather than dealing with our pelvic support or fusions?
I think first of things is that I think it's always important to discuss this with the colleagues together. To have a joint collaboration is nothing short of this, because some great ideas can come from this and we can all agree to this. But saying one thing is that, of course, with the osteotomies, they deform the proximal femur. That becomes challenging for us. They go in, they've already, the soft tissue is kind of compromised. So I think that, yeah, of course, if the hip is in a situation where the results are very unpredictable, I think it's better not to touch them. But, and it also depends. I mean, as Atamar says, lots of variables and co-founders. What's the age of the patient? What's the activity limitation? What's the degree of pain? So many things are there to look into. But generally speaking, I think especially pelvic support osteotomies, there's a huge pelvic tilt. Although some of my colleagues says that if you do it in future, they remodel.
Yeah.
And they remodel and they you don't have a major problem with that. But I'm a little bit hesitant to sort of have a look at it. On the established side, on the other hand, if there is an osteotomy done there, and if the metalwork is removed, it just gives you that concentric hip, as I showed you some of the examples, that it's much easier to sort of place the established shell without using the augments or the bone graft, you know. So you get a very good coverage. The whole shell sits into the native bone, which with the bone ingrowth there, the longevity, I'm very sure that it gives you an added advantage of this,
So based on your experience, how long would these hip replacement, if you operate on a patient who's 12 to 14 years of age, when would you expect to do the next revision?
Okay, that's a great question. I think there are a couple of things which are important. First of all, important to sort of surgical technique, that you've got to use the correct implants. That is extremely important, and have a very good stable fixation. With the new implants, I mean, we're really excited. I think with the ceramic on board, we're looking at the longevity with these younger patients, even though they're very active and they have great social life and, they want to run around, you're looking at good 20, 25 years, if everything goes on well, inshallah. I think you're looking into that. They're coming in. We've just seen all these systematic and, meta-analysis. But we are very, very optimistic about their longevity.
Okay, so let's see if we have some questions in the chat. Okay, unfortunately, there remains a clear treatment gap for patient A. Dr. Abdullah is mentioning that the majority of the arthroplasty surgeons that maybe he works with them prefers to push the patient until 18 years of age, despite considerable pain.
I tell you something. I take life as, it's a privilege from Allah subhanahu wa ta'ala for us, for all of us. It's a great thing to have. Pain is not a good thing, to be honest. And I don't like children who come very sad and who sit alone in the corner not doing this. Imagine this life. This is not life. And, we know, all of us know that, you push these children to the physical therapist, what are they going to do for this? If the hip is not functional, it's not to blame them. It's that they cannot do much about this. So what else options you have? You just tell them to live your life like this. I mean, so I am more aggressive with them, and I tackle with them earlier, and I tell them the risks, the pros and cons. It's not that I don't tell them. But during the surgery, of course, you need to make some adjustments. The most important thing is that you have to make sure there is no impingement. So your hip is sitting in a place which you take this good range of motion and it's not impinging anywhere. If it's not impinging, nothing else will sort of hurt this hip. And if your bearing surfaces are good, then you're good to, you're at home. Okay. So my indication would be younger patients.
What's the youngest patient you've operated on?
So we've done 11 years old. Thamar knows we were together with this, and 11 years, I think, is the youngest that we've done. But I think, you know, I think 9 or 10 years old probably can also be a candidate, if they're really suffering. So you've got to choose them very carefully. And I'm saying about those patients who have no other choices. So these are not the patients that you're thinking, oh, maybe the osteotomy will do and they will do well. Yes, there are patients who have DDHs and you have a good concentric head and CEA angles and all those angles you measure, and then you give them 15, 20 years, very good. If you can send them back to the schools and recreational activities without pain or minimal pain, let's say, it's excellent. Let's be them. But this is that cohort of patients who've had complications and who are suffering. I don't think you can leave them alone.
Okay. Dr. Ziad, I have a question. Says, from your experience, how many DDH cases have you were previously operated on? And what is the usual age at which patients present to your clinic?
Okay, that's a good question. To be honest, I don't have the statistics in my hand right now, but most of these patients, the CROWS 4, the ones that we've done. So as I said, the series is more than 100 and 130 or 40. These are the ones which were not dealt with before. So they were neglected. They came up, most of them. And the ones which is the two or three were operated before, the ones that I showed, they had pelvic osteotomies. So I'd say that, I think 60% maybe were operated before.
Okay.
And they came with secondary osteoarthritis.
Another question from Dr. Mishari saying, is there any specific rehab tips for those patients post-operatively compared to the adults patient?
I think the important rehab would be, first of all, you have to basically teach them very well. This is one dilemma we have. Of course, they're young children. They cannot entirely know what's a total hip and how to protect it in the beginning. So you have to actually, not only the patient, but the parents, you've got to really involve them right now. Teaching, I think, is the most important thing. So the first 2-3 weeks, I am very aggressive to tell them to limit their range of motion as much as possible. I kind of scare them because I don't want instability in this. By 4 to 6 weeks, the physical therapy and rehab with the hip is much more different than the knees. Total knees, they need excessive rehabilitation. But with the hips, when they walk, they become okay. The lurch disappears by itself. But after 6 weeks, they can go through a period of rehab with the physical therapist, training them how to strengthen their abductors particularly, because that's where they get rid of their lurch. If you have strong abductors, that's what you need.
Okay, nice. Dr. Dalal, she had her hand raised. I think she wanted to ask a question. Dr. Dalal?
No, I just wanted to comment. I will say thank you, Dr. Amna, for the great topic and the great speakers. Hi to Dr. Tamer and Dr. Ilyas for the great discussion. What I can take as a conclusion is that we can be brave in doing all the DDH now after Tamer's lecture. And we feel safe because we know that Dr. Ilyas will do total hip if we do something wrong. That's the conclusion of this lecture. Thank you all and see you all. يعطيكم العافية.
Good to hear from you.
هلا والله دلال, حياك الله, الله يمسيك بالخير.
Let's see if there is any other questions. Dr.
Dr. Amna, and I would like to ask Dr. Imran. I mean, he's all the time صحيح working with me in the same place, but he's busy and we don't catch him to ask him. Now it's the time to ask. I'm amazed as usual, Imran. Wallah, I'm very happy for those children to retain their life, especially the chondrolysis group. It's a radical change in their life, especially ladies. They can't look after themselves with stiff hips, definitely.
Absolutely.
Imran, just 2 questions. First of all, this kind of surgeries for younger children, what's the percentage of arthroplasty surgeons who are capable of doing them? I mean, you see, the other colleagues mentioned that most of the arthroplasty surgeons, they are pushing them away till the age of 18, maybe till the age of 60, till they die, and they will never operate.
Tamer, my arthroplasty colleagues are all very excellent, mashallah. They're all very skillful. It's just, I think it's, the different training and different knowledge. And of course, you can bring lots of papers and literature, my colleagues can bring a literature and they can tell me, oh, look at this paper, which shows a failure rate in 10 to 15 years. Then what you're going to do? So you should buy time, ishtari waqt. This could be a thing,
Yes.
there, but I think they're all very capable to answer your questions. It's just, I think the literature that they read maybe sways them to a little bit more conservative approach. And I don't kind of blame them in a way, because some of them, Tamar, will come on to revision. I'm not saying that they will not have, because, some of them have very small sockets.
Yes.
When they have very small sockets, polyliners is very small. And ceramics don't come that smaller. So you're bound to put polyliners, or you put all polyliner, which is cemented in. So when they more challenging for them, maybe they're feeling this way, but it's easier actually.
Mhm.
Revise the tips.
Seems
So
to be a connection with me a bit. But you see the message.
I think as time will grow by, and also we are now in, people are going on to the moon and orbiting around. We need the want to, if they want to walk. I remember the first time I came, Thamar, there was a patient, and that lady was like 35 years. She said, I want to do the same procedure that your predecessor did. And what was that? What was the girdle stone? That was the most important procedure. The girdle stone procedure, she was happy. She never wanted to do a total hip replacement. And why was that? Because all she wanted to do was to sit on the floor and have her meals with her children. You see? So see that mindset. Now we're there. Now in this age group, the girls are playing sports. They're going out everywhere. So you cannot deny them this opportunity,
Definitely, but you see,
And Tham, I have a question for you, please.
okay. I'm having issue with connectivity from my now.
Thank you for your fascinating.
Yeah.
This was it. Yeah, sure. Ashra, you showed some very fantastic case, and you relocate some of these hips, and you can do them 9-10 years of age without doing the shortening osteotomy. My two questions. First, when you get the hip back, is there any way that you can find there is a mismatch between the acetabular cavity and the femoral head? You mentioned about CT scan. That can you make some measurements that you know beforehand? And the second question would be, do you have
definitely, Imran.
vascular necrosis?
Definitely, Imran. What I was mentioning to the attendee, that large femoral head really is a big concern. You are dealing, especially in those what we label as Tunis 3, they are sitting at the rim. They are damaging the femoral head is damaging the rim of the acetabulum. So you have a shallow acetabulum, very narrow, not much of depth, and you are having a big femoral head. When you put it in, whatever osteotomy you do, you will never contain the femoral head in a very secure way. They are definitely at a higher risk of redislocations. No matter you do soft tissue balancing, bony wise, it's quite difficult. So you don't have the idea of reaming or doing what you do in arthroplasty, creating a good space. We are dealing with what we have. So this, I believe, one of the factors that you need to think twice before going. If there is a damaged acetabulum to large extent, I think you will struggle intraoperatively to put the femoral head. If it is a small femoral head, I think your job is easier. But if it is large, irregular, I think you need to think twice. The second question, Imran, you see, you mentioned that to me so many times that it's easier for me to revise my total hip compared to a hip that has been reconstructed with femoral and pelvic osteotomy with I would say soft tissue not respected.
Correct. Yeah.
This is the issue, Imran. You see, if we have arthroplasty surgeons who are familiar to do the young adolescent, we will never touch children. But you see, I believe that my colleagues in pediatric orthopedic, they don't have this kind of collaboration with arthroplasty surgeons who are willing to operate early in life for this purpose. That's why they are doing some varus, valgus, triple pelvic osteotomies, trying to buy time till the arthroplasty approve their surgery. But from your experience, revision is easier.
I tell you why, Sama. This is very interesting. And when we started doing, this was my concern. And of course, I knew that I would one day have to revise them, because at that time they were very thin. They would wear out, and they did. So the problem, but when you put the hip there, what happens is that as the acetabulum starts to get loaded, for some reason, the bone quality gets improved. This is what happens. So when you go for revision, you find, alhamdulillah, you find more bone quality. You then just have to take that shell out, and you can actually ream more, because before that acetabulum was never loaded because the femoral head was not in the socket, it was out. So the bone quality, it never grew. When you put the socket and you put the hip back in, it loaded that acetabulum. So the periacetabular bone stock improved for some reason, and the child grew. So when you came to revise it, it was easier.
Thank you so much, Imran. I think this is. We'll not do any surgery خلاص anymore.
Okay, so I have a couple of questions from the audience for Dr. Imran. One of the, I think Dr. Ibrahim said, knowing that those patients have a lot of deformities such as rotational problems, hip problems, what are the prerequisite imaging that you usually do before you take them for hip replacement?
Sorry, Dr. Amna, your voice was breaking a little bit.
Sorry. Can you hear me better now?
Can you the last?
I'm sorry.
Yes.
Yep. So, what are the prerequisite
Yeah.
imaging that you do for those patients with the late presenting DDH before you take them for the hip replacement?
Important. The pelvis, which is standing, and then we take the whole spine X-ray and the whole limb, lower extremity, because remember, these have effects on the knee. As the hip dislocates, it actually puts the hip in varus. Going out, it puts these whole femur into varus or inside, and it puts the knee into valgus. So I've seen some very severe valgus deformities of the knee joints, And then the foot deformities also happen. So that's important. And also the spine you have to, because you have to see how flexible the spine is. Because, you remember, this is a spinopelvic junction. This is one complex. As the spine flexes or the pelvis flexes, the acetabulum retroverts. So pelvic goes forward, the acetabulum retroverts. The pelvic goes backwards or retroverts, the acetabulum goes anteversion. So some of these cases, I also do a standing and sitting X-rays lateral of the pelvis to see how the lumbosacral junction functions. This is extremely important, because if it is not functioning well, then you may have to sort of orientate your acetabulum in a different place, or try to sort of look into other options, like maybe a dual mobility shells,
Okay. Another questions from the audience.
And CT.
And CT scan, of course, yeah.
And CT.
Based on your experience, which patient does better post-operatively? The ones that were non-touched with the high-riding hips, or the ones that were operating or operated by us? Okay,
no, well, you guys do an excellent job, really, with a very complex problem. I saw Tamer's cases and all of you, mashallah, excellent cases.
You're comparing apples to oranges. Dr. Tamer is an expert.
So what happens with the DDH, which is outside, and Crow's 4, you see, that is technically very demanding, very challenging. And if you read the literature, and if you read the arthroplasty books also, the most challenging procedure for arthroplasty surgeons is the Crow's 4. And you know why? Because there is no anatomy. The anatomy is disturbed. And you have to be really careful with the acetabulum, which is very shallow. The smallest size reamer that you start with is 36. Sometimes you do an osteotomy around the acetabulum to just make some place so that you can insert your reamers. Now, when you insert your reamers, we don't actually do forward reaming. We do reverse reaming. The bone is so soft, and then you have to orient it. So technically, this is a very complex case. When we get a case who's developed arthritis after the reconstruction that have been performed by your good selves, it is much easier, as I've shown you some examples. Then all what you've got to do is to ream the acetabulum, do the acetabular shell, and get out from there. That operation is 1 hour, 1.5 hours, something like this. But with this osteotomy stuff, getting down to really deep inside the true acetabulum, the small one, then doing the osteotomies, looking at the sciatic nerve, that's the complexity. So it takes longer, definitely.
Okay. Let me see. This patient, what surgery can it? One of the audience have a question. Dr. Tariq said, what is the incidence of dislocation in these patients? And what strategies can you do to prevent that after hip replacements?
Excellent question. we've had our share, but I would say fortunately not too much. The instance would be higher than the regular hips. So you could say that maybe 2%, 2 to 3% risk of rotation. And what you do is the key for these cases is that intra-op. When you put these hips intra-op, you have to make sure of a few things. One thing is the orientation of the acetabulum and the orientation of your femoral component. Now, sometimes people tend to put it too anteverted because they don't want dislocation posteriorly, but they forget that this will dislocate anteriorly.
Yes.
And this can happen because what will happen is that as you put the anteversion of both, so this is the place where we have the concept of combined anteversion, the anteversion of the acetabular component and the femoral component. This should be regular. Now, sometimes with these patients, I am very neutral we are very neutral with our femoral component, because if we would antevert our femoral component, it would impinge posteriorly. The neck will impinge on the edge of the acetabulum and dislocate anteriorly. And also, when you antevert them quite high, your cradle trochanter goes back posteriorly. So you don't get that good abductor lever arm that you need. So intraoperatively is the best part. And unfortunately, this just comes with experience. And what we do is we do the osteotomy, and people ask me, the second question can be, how much osteotomy should you do? It's all dependent on the sciatic nerve. So we isolate the sciatic nerve, we look at it, and we look at the tension that it has. We do the shortening osteotomy, and then you can do an overlap and make sure that it comes to the right place, but don't over tighten it that the sciatic nerve gets stretched, because that's very easy to do it. So these are a few tips that you can do. The other tips would be, I am not in favor of putting up a hooded liner. I think if you put a hooded liner, that means you've really not sort of played well. In 99% of cases, or even now almost all our cases, it's no hood involved, because hood is a problem. Already the head is small, you will have impingement, and then you have a wear from these. So have as much free hip as possible. That's very important. And see the arc, do the telescoping, see how does it feel, because the intraoperative is the best way. There is really no other way. Now, if you have the luxury, now we have the G7 cup, which is the Zimmer dual mobility. I think that's another excellent option that you can have in these cases. Because even though if you have a 44 shell or 46 shell, you can put a dual mobility, and that gives you an added stability component in these cases.
Okay. There is a very nice question. So what are the things that you've faced when you operate on patients that we've operated on in terms of soft tissue handling? Because you said soft tissue balance is really important. Is there anything that you've encountered during your operations in patients post-open reductions and pelvic osteotomy that you think we can do better to facilitate your approach or your outcomes after hip replacement?
Yeah, with the pelvic osteotomy, and I think Thamar mentioned that before, the hardware placement, which is there already. Now, fortunately, he removes all his hardware, which is so good, thank you very much. This can increase the timing of the surgery. So that's one thing. But when you operate on these patients, you really give them 10, 15 years, which is excellent, because by the time they need the total hip replacement, the scarring is much less. The only problem that we face is the hardware that is present. Sometimes we see some screws going up for the pelvic osteotomies. Mostly K-wires. K-wires don't trouble us too much because we can pull them out. The last case I saw we didn't pull it out, but it's not in the way, so we didn't feel like, because they were buried inside. But hardware is the most important thing. Soft tissue after 10, 15 years doesn't cause too much of a problem. And of course, we can then modify our approaches. We have to be very careful to look at the abductor muscles. And for a hip surgeon, for me, the most important muscle there is the hip abductor muscle. I have to take care of that muscle. And if it's not functional, we have to do something else. We have to, as I said, the Leo Whiteside procedure, we have to transfer, we have to do it. Because for me, the hip replacement is not successful until and unless the patient is walking without lurch or very minimal lurch, because you may have done an excellent approach, but if the patient still lurches, for them the operation hasn't sort of worked well. So I think the scarring is not too much an issue, because it is, and most of the cases that you do is the lateral approach. So and we do a posterior approach. So we go through an approach where it's not been violated before. So it's a pretty straightforward. With the soft tissues, because you put it in place, so you put the abductors also in place. So this is another good advantage. So again, no adjustment is required in that case.
Okay. One last question for Dr. Thamer. When you're operating on those patients that are late presenting, when do you start physiotherapy? You said your protocol is to put them in a spica cast for around 6 weeks and then a broomstick cast from 4 to 6 weeks. Then do you start them on range of motion exercise? Do you wait?
They are difficult patients, let's agree upon this, but they need, you see, I send all my DDH cases, maybe some will disagree with me, even the younger patients, I'm sending them to physiotherapy. So I know some physiotherapists who are familiar with the post-open hip reduction pelvic osteotomy protocols. They know how to deal with the patient. They give them the proper chance for weight bearing first, because they are osteopenic, most of them after surgery, to prevent the fractures. Then they have slowly with the range of motion. But it's a device for any surgeon who's planning to operate on a delayed presenting DDH. Recovery of range of motion can take up to 3 years. And there is no guideline when to do manipulation and anesthesia for those children. So don't get disappointed that the patient will present to you 1 year, 18 months, almost 2 years from surgery with range of motion not reaching 50% of the normal side. At some stage, they will recover. I would say to 80%, 90%. I'm not talking about patients 14 or 15 years of age operated. I'm talking about this kind of reasonable age, 9, 10, 11 maximum. I think they need more time. If you have a motivated child, a good physiotherapist, they might recover within 18 months, not before that.
Okay, nice. So to summarize, from what I got from this talk today, if we have patients with late presenting hips, if it's unilateral, I'll try my best to operate on them. If they have a good shape of femoral head, a relatively good shape of acetabulum, and an open triradiate cartilage. If they're bilateral, and again, with those good signs, I will try my best to operate on them. I'll need to talk to the family, make sure they have a good education. The consent needs to say stiffness is a complication, ABN is a complication, redislocation is a complication. If they redislocate, we should not operate on them again. If we think that we did everything intra-op and we're not worried that we missed something, because the reoperation after redislocation will have a worse outcome. Then we'll just follow this patient. Once they have severe pain that is affecting their daily activity in that age, we'll try to find a good arthroplasty surgeon who would be happy to operate on them rather than doing a pelvic support osteotomy or a hip fusion that would affect the abductors and or will cause a lot of deformities of the femur that would affect the hip replacement later on.
Perfect.
Thank you very much for this very rich discussion. I really did enjoy it, and I hope all our audience enjoyed it. We are blessed to have both of you guys here to learn from you. Our patients are very lucky to have you guys here. And thank you for everything that you do. I know there isn't anything physical that would be enough for all your efforts for your patients and for us. But inshallah, da'wah, or inshallah, ajr عند الله بإذن الله is more important. Thank you very much.
Thank you so much. We are very optimistic that pediatric orthopedic scientific work will be definitely with you and your colleagues in the chapter. Inshallah, it will take another dimension. We are very looking forward for that, inshallah. All the best. Thank you so much, Imran, for enlightening pediatric orthopedics all the time.
Thank you, Samer. Thank you, Dr. Amna. Thank you, all the audience. This was a great experience. I really enjoyed it. Very educational.
Thank you very much, all.
Take care. Bye-bye.